respected chairpersons and moderators, and I thank Dr. Rajiv Garg and Heart Failure Society of CSI for giving this opportunity. And as we have non-steroidal MRAs, but still we are using steroidal MRAs in a large extent, and what is known to us and what we are going. So steroidal MRAs we very commonly we use in patients of heart failure with reduced ejection fraction. But in patients of heart failure with preserved ejection fraction, this topic is always a controversial, and we have not used it to a greater extent. Not been studied, but not proven. And whatever the results we have, we had a lot of controversial results on this subject. And so let us go through the what is evidence and what is going to come, and what are the evidences which we are lacking in this field that should be known to us. And so as we know that HFpEF is actually almost 50% of all heart failure cases worldwide, and it is increasing its prevalence particularly in hypertensive, in elderly population, in diabetic population. And there is always a high morbidity and mortality, and patient requires frequent hospitalization despite ejection fraction is normal. And almost the MACE event rates, cardiac event rates, almost they are similar to heart failure with reduced ejection fraction if you don't treat in a proper earlier. And mortality, as I told you, is similar to heart failure with reduced ejection fraction in long-term follow-up. So there are various comorbidities, atrial fibrillation, chronic kidney disease, obesity, anemia, and many times some respiratory diseases, coronary artery disease, and there is a systemic inflammation, endothelial dysfunction. All these things are going hand in hand when patient is having heart failure with preserved ejection fraction, what we call it as HFpEF. So this is basically concentric LVH, stiffness of the left ventricle, systemic inflammation, as I told you, endothelial dysfunction, myocardial fibrosis plays a central role, and there is a neurohormonal activation which perpetuates the progression of the disease. So this is all is going on. What is in a short the pathophysiology. I want to go into detail of this. And so aldosterone basically promotes the sodium retention, vascular stiffness, and fibrosis. And this is renin-angiotensin system is activated, and mineralocorticoid receptor activation leads to myocardial remodeling. And we need to block these MRAs, they block these aldosterone mediated maladaptive pathways. And that is how this concept of mineralocorticoid receptor antagonist came. And spironolactone and eplerenone, they are basically a steroidal MRAs, what we have at present, and they inhibit the mineralocorticoid receptor binding. So it has basically anti-fibrotic, anti-inflammatory, natriuretic effect, and it improves the diastolic function and reduces the congestion because of that. So spironolactone is basically a first generation MRA, and it is a non-selective. It also binds the androgen and progesterone receptors, widely used in heart failure with reduced ejection fraction, resistant hypertension, and hyperaldosteronism. Side effects like gynecomastia is very common, particularly in male. And eplerenone is a second generation MRA, more selective, fewer sex hormone related side effects, and it has been well studied in post-MI in EPHASIS trial and chronic systolic heart failure in EMPHASIS heart failure trial. Little costlier, shorter half-life than spironolactone, but works very well if you use properly. So basically, the landmark trials were done. There was a RALS trial in 1999 which showed the mortality reduction by 30%. EPHASIS, eplerenone improved the survival, but they were all systolic dysfunction cases, and EMPHASIS also was used. So these are the trials which were done, and it is established MRA now in the patients of heart failure with reduced ejection fraction. So all of them, they are very well established, and the rationale is because they have anti-fibrotic effect, neurohormonal activation comes down, congestion comes down, and MRA may reduce the hospitalization and improves the. So the only trial which was done was a TOPCAT trial, which was using a spironolactone in heart failure with preserved ejection fraction. and it was around more than 3,000 patients with ejection fraction more than 45% versus placebo, and CV death, cardiac arrest, hospitalization for heart failure, and followed up for 3.3 years. And what they showed is overall neutral for primary outcome, but what it shows is significant reduction in hospitalization for heart failure. There were some differences, regional differences were there in Americans versus Russian and Georgians, and adverse events like hyperkalemia and increase in creatinine was seen in this group of patients. So only positive outcome was heart failure for hospitalization reduction, as you can see. And the regional differences where patients from America showed clear benefit, like Eastern Europe side had some unusual event rates, and it raised the concerns about the trial conduct and heterogeneity when this trial published. Interpretation of the results also impacted. So it was not overall a positive outcome trial, and it fallen into a controversy and dispute, and then this drug was not approved at all. You can use it depending upon the physician's discretion. If you want to reduce the decongestion and patient is requiring recurrent hospitalization, in those cases, as per the physician, can be used. Other evidences, like there are smaller studies, registry data is possible, reduction in readmission, ongoing debate about the reproducibility and the patient selection. So meta-analysis, pooling of all the studies, it again shows the reduced ejection fraction, almost similar results. There is no consistent mortality reduction. Subgroup benefit shows better effects in females and obesity and those who had higher NT-proBNP, and again the heterogeneity remained. So the subgroup analysis, women may respond better, obese patient improved remodeling markers, CKD patients were limited by the hyperkalemia risk. So safety profile, hyperkalemia is more 2 to 3 times as compared to any other drug, and renal dysfunction limit the tolerability. Elderly and CKD patient again required close monitoring. Eplerenone is safer but not studied well in heart failure with preserved ejection fraction. And there was only small study was done for eplerenone I could find in the literature, was a HFpEF study published in 2011 in Journal of Cardiac Failure with only 44 patients. It was a double-blind randomized control trial, and again it shows there is no difference, and for only small mechanistic randomized control trial was done, there is no demonstrated improvement in exercise capacity on hard outcome. So to summarize, guideline says that MRA, but they did not specify which MRA actually. So HFpEF MRA receives class 2B indication, and careful monitoring of potassium and creatinine is required. And the most studied is basically a spironolactone rather than eplerenone, and in this group of patients. So eplerenone in heart failure with preserved ejection fraction is limited, and we do not have much data. Can be used, but with more evidence is with spironolactone, which only one study which has been done. It is a class 2 indication and can be recommended in this group of patients. So there is not much robust data is available, and again, so underused due to safety concerns because of the physicians do not have much confidence of using this molecule. And as the SGLT2 inhibitors has now been approved, this molecule has fallen into the backstory. What we have to do of future directions in future is precision medicine, fibrosis predominant versus metabolic HFpEF. So there is a difference between these two groups, and we need to target the biomarkers guided therapy, and combination therapies should be investigated like MRAs, SGLTs and ARNI, and cardiac MRI should be done to know the fibrosis in this group of patients, and particularly those who have more of fibrosis and where NT-proBNP levels are elevated, then this drug may be beneficial to our patients, particularly those who are having HFpEF with the fibrosis predominant, and echocardiography indices, cardiac MRI, T1 mapping for fibrosis quantification, and potential to guide the personalized therapy, individualized therapy for one group of patient is very, very important. So MRA reduces hospitalization for heart failure, and if you have patient who is requiring recurrent hospitalization, you may use after doing some cardiac MRI where patient has more fibrosis, which patient may likely to benefit where the NT-proBNP levels are elevated. So precision use of MRAs in fibrotic HFpEF, synergistic role with SGLT2 inhibitors and ARNI, an emerging role of biomarker and cardiac MRI guided therapy, and need for new randomized control trials in this diverse population should be done. And it is a promising but underused in HFpEF, and the future lies in precision combination therapy with real world validation. Thank you very much.
Thank you, sir, for capturing the essence of it. Do you feel that the Georgian and Russian protocols were not followed that much?
Yeah.
And that probably tilted, that is depriving us of a very, very potent drug, because I personally feel that the answer to a HFpEF lies in reducing the stiffness. And probably MRAs are the best ones which would reduce the stiffness and would permit rather than anything else.
Yeah, actually, once you have such kind of differences, you should go for some other few more trials so that it gives evidence. But maybe patient, this particularly drug is not having that much support in terms of doing some kind of randomized control trials. Financial support also is required for doing some kind of big. So being a spironolactone is not very costly drug. So doing such a big trial also requires a lot of finances. I think drug was lacking that, and it was done, but maybe in half-hearted manner it was done, and no other the drug was tried in further. So I think clinical judgment of a physician is very, very important when you are using this drug. And many of the times we are using in combination with diuretics, the spironolactone is written, and the patient gets directly or indirectly the benefit of these medications. And once the decongestion happens, and nowadays we are using SGLT2 inhibitor, so we tend to stop loop diuretics after some time, and in my practice I continue the spironolactone and SGLT2 inhibitors, and they do very well. So along with the newer therapies like weight reduction and use of GLP-1 antagonist and all, so newer therapies should be targeted along with the older drugs, so that a combination of therapy patient gets more and more benefit out of it.
Any questions from the audience? Otherwise, or comments from audience? We move to the next talk.
Yeah, actually, I am speaking on the another talk, which was actually scheduled in the morning, and the organizer requested me to complete the talk. And it is again, you can say it is a similar background relevance of obesity in cardiovascular disease management. Actually, I should have spoken this first and then the therapy, because again the obesity has in association with the HFpEF. And so I will be going little quickly. And obesity is a condition with excess of adiposity without abnormal distribution or function of adipose tissue, arising for multiple causes. And Indian prevalence, as we see that overall prevalence is around 28%. Abdominal obesity is almost like 40%. And 1 in 8 people in the world, they are living with the obesity. And this BMI more than 25, overweight is more than 30, is obese. And this is what the definition says. And economic and healthcare burden is huge, driven by this cardiovascular disease is a major burden in India. And almost healthcare expenditure is increasing by 80%, and cardiovascular diseases are increasing. So we know all these statistics and facts. And it is like an independent cardiovascular risk factors. And whenever we are talking about cardiovascular disease, we talk about the obesity. We are always giving concentration on hypertension, diabetes, dyslipidemia, smoking, and we are not using a BMI or waist-hip ratio as one of the factor in our day-to-day practice. And I think it should be given a lot of importance, because most of the diseases, they come from the obesity, and it is basically a tip of iceberg what we see. And if you dissect into the details in depth of that, you will see there are many problems this patient is having. So mechanisms like social, environmental, economic, biological, there are many factors are there for an obese patient. and usually it has increased risk of high blood pressure, renin-angiotensin activation, abnormal lipid metabolism, and sleep-related problems. So rather than going into much of details, what is more important is obesity paradox. So most of the trials has shown that obese patients, they do very well. They have good outcomes. And the paradoxically, several retrospective and prospective studies has shown that obese patient has better survival. And that is as compared to the normal weight counterparts after the onset of cardiovascular disease. And this phenomenon is called as obesity paradox. And this paradox is well documented in patients of heart failure, reduced ejection fraction, preserved ejection fraction, particularly in class 1 type of obesity. And overweight and mildly obese heart failure patient shows a lower mortality and better prognosis as compared to the normal weight or underweight patients. And they have increased CRF, energy reserve. These are the reasons why. And they have good higher muscle strength also, skeletal muscle strength, improving the exercise capacity and the prognosis. So these are some of the possible mechanisms, but whether it is a real or it is artifact, that is the question. So in these patients of heart failure, the oxygen consumption more than 14 ml, the obesity paradox disappears, indicating that survival benefit is mainly observed in those with the low CRF levels. And obesity cardiovascular links has extremely studied through various MR and observational designs, and however the evidence largely focuses on single outcome with limited consolidation of multiple cardiovascular risk factors. So clinical outcome, obese HFpEF represents the distinct phenotype with increased plasma volume, concentric remodeling, pericardial restraint, and worse exercise capacity compared to a non-obese HFpEF. And among the heart failure subtypes, obesity studies, heart failure with reduced ejection fraction comprised of almost 45% and HFpEF for almost 40% of the cases. So every 1 SD increase in the BMI confirmed with almost 1.3 times higher hazard ratio for these patients as compared. So there is nothing paradox, that is only superficial observation, but actually the obese patient, if they have heart failure, they do worse as compared to the non-obese patient. So there are various beta blocker therapy can cause weight gain, management issues are there, and there are various drugs what we have been using till now, like sulfonylureas, and there are many drugs which like insulins, what if somebody is diabetic, all of these molecules, they increase the weight gain of a patient. So always there was a search where there will be a weight neutral molecules, and basically the SGLT2 inhibitor was one of the first molecule which almost caused some kind of weight reduction in this group of patients. And exercise, so this is atrial fibrillation arrhythmias are also very common in this patient, and obesity related comorbidities like obstructive sleep apnea, hypertension, heart failure with preserved ejection fraction, all these things they also increase. So the coronary artery disease, almost 70 to 80% of the coronary artery disease patient, as I told in the beginning, we are not giving much importance to the weight. We always concentrate on the established traditional risk factors, and there is every 5-unit increment of BMI, the risk of coronary artery disease increases by 30%. And the management difficulties, again rehabilitation program, and these patients, they are little poor in the adherence of the treatment, and usually the drugs whatever you are giving, they do not work well them, and again they have very high incidence of pulmonary thromboembolism or venous thromboembolism. DVT incidence increases by almost 2.5 or 2.2 for pulmonary embolism. And again the dosing, whenever always there is a 110 kilo patient lying on the table for coronary angiography or angioplasty, for me is always a dilemma how much heparin I should give, whether we should exceed beyond 10,000 and whether we should give 11,000, 12,000. There are not much studies are available, and always we need to check the activated clotting time and the anticoagulation doses also. When we are giving enoxaparin, they say that 100 milligrams is the maximum dose. You cannot go beyond that. But always a worry is to me what happens if I underdosing this kind of patient in a more than 100 kilos patient, and what kind of anticoagulation dose we should give, because they have not been studied. We don't know what kind of dosages we should give. If somebody is 130 or 140 kilos, whether we should give 140 milligrams of enoxaparin, it has not been studied. 14,000, 15,000 of unfractionated heparin we have not been given in the cath labs. So DOAC also more than 120 kilos and 40, these were not studied in any of the clinical trials. So dyslipidemia incidence also is very, very high, and almost 60 to 70% of the patient exhibit dyslipidemia. Around 50 to 60% patients, they are overweight, and weight loss drugs shows only modest variable improvement in this group of patients. Statins are effective but often need a combination therapy. Bariatric surgery, but it is again a difficult problem, and hypertension is very common in them. It is per se because of the weight, also because of neurohormonal activation, and also the contribution is by the obstructive sleep apnea, which also contributes to the greater extent, and it leads to the increase in the hypertension in this group of patients. So screening and diagnosing is very, very important. Limitation of BMI. Always BMI is not correct. So we need to go for waist hip ratio, waist circumference ratio. So all these parameters, waist hip ratio, waist to height ratio, all these things needs to be considered, which are alternative measures. And but the most probably is BMI and the waist circumference are the most commonly studied in most of the clinical trials, and other parameters has not been studied to the greater extent. So cardiac imaging and biomarkers should be done. HSCRP levels, usually the NT-proBNP levels are elevated, and usually it signifies this patient is having some kind of heart failure with preserved ejection fraction. So there are diagnostic challenges are there, and breathing difficulties, fatigue, edema, it is very, very common in them, and sometimes there's masquerades the cardiac symptoms, and most of these patients tend to over-diagnose some of the cardiac conditions because of the weight itself, and they may not be having. So what are the therapeutic approaches like dietary modification, and usually this dietary modification, we advise them, they usually try to go very sincerely to the nutritionist or dietitian, but usually following, and it doesn't happen in reality, and haven't seen many cases where obese patient has become a non-obese by using only dietary therapy or dietary management, despite so much about the nutrition and diet, behavioral interventions and barriers. But again, it has some kind of limitation. Cognitive behavioral therapy and family and other family members should be involved, and it should be encouraged, but usually they suffer with stress, depression, emotional eating, and psychosocial is very, very common. There are many drugs came into picture, but most of them they failed, and now the promising drugs are like semaglutide and tirzepatide, but they are too early. We do not have a very long-term data. Recently these drugs came to India, and hardly few months we are having injectable semaglutide of 2.4 milligrams. Hardly 2 months or 3 months we are having this molecule, and tirzepatide also. So we don't know much of or any long-term side effects of these molecules. We don't know. All other medications which used before, they have outdated and nobody uses them, and they are now contraindicated and should not be used. Incretin receptors, they are promising, and they have shown a significant reduction of the cardiovascular benefits also, and it has shown the benefits in terms of the metabolic related fatty liver, and also the renal benefits has been shown, cardiac benefits has been shown. And the first trial which was done was a select trial where the non-diabetic obese patients were randomized, and they have shown that it reduces the significant weight loss by almost 5 to 10%, and the major cardiovascular events came down in this. So now dual agonists like GLP-1 and GIP tirzepatide with SURPASS and SURMOUNT trial, which shows the potential cardiovascular benefit, has come into the picture reality. And maybe bariatric surgery is been now approved by US FDA, and the problem, it has its own limitation, and it should be done. If it is done really, it has shown that it reduces the various risk of coronary artery disease, myocardial infarction, heart failure, CVA, and cardiovascular mortality. And there are large cohort analysis and meta-analysis has shown that it reduces all-cause mortality, heart failure, myocardial infarction, and stroke. So overall, bariatric surgery provides a durable long-term cardiovascular benefit in obese patient, but a real motivation and the financial support and a good cardiac, good surgical center, bariatric center where these surgeries are performed is required, then only you get a good benefit of that. So take-home message is obesity is a central and modifiable risk factor which needs more and more attention when we are, as a cardiologist, when we are treating a cardiovascular disease development and progression. And obese patients, they have definitely, there is nothing called obesity paradox. Definitely these patients, they are at higher risk of developing cardiovascular diseases, and unique diagnostic and management challenges are there, and that we know as day-to-day practice, everybody is seeing these kind of patients. And we need a comprehensive multidisciplinary approach for the treatment, and newer modalities are coming. I think they should be offered to these patients so that we improve their long-term outcomes. Thank you very much.
Thank you, sir. The Indians are different population, so we call ourselves as thin fat Indians. And the BMI for us to label obese is 22.9. So anything above 22.9 BMI becomes obese. So do you feel that it is justified that we start anti-obesity medications and treatment?
Actually, abdominal obesity creates more problem for our Indian patients, because once upon a time we used to think that the fat is something called inert and it does not cause any problem. But I think most of the inflammatory markers and everything is coming from the abdominal, whatever obesity it is there. So, and that's why we are the capital of everything, all the metabolic disorders in our country. So, definitely we are different as compared to so what we call it as a Southeast obesity, and which needs to be addressed. And but overall, whatever is this obesity, what you call, the approach remains the same. And as the good thing is that most of the Indian patients are now getting enrolled into the clinical trials, so we have data now. So earlier days, the Caucasians and the Asian patients means we used to have mostly the Chinese and Japanese, but now the South Asian patients are also getting enrolled into the clinical trials. So now we have data of our own patients, and whatever it may be, the SGLT2 inhibitors, if you see in EMPA-REG outcome trial, the maximum patient which got benefits were the Asians. The hazard ratio was 0.37. So as compared to the other part of the world. So if whatever therapy you give to the Indian population, we are going to get the maximum benefit, because whatever the obesity you label is, I think, one of the worst obesities in our country. So
yeah, that is true for even SOUL trial, where almost 800 patients out of the 9,000 patients were Indians, and the maximum benefits, 27% reduction in cardiovascular outcomes was for particularly Indian patients.
Yes.
If I may, I have a question as well. So I think, first of all, I mean, the discussion about cutoffs on BMI and so on, I think probably it's not really to be applied to India, but rather to China, Japan, so where overall the body surface of people is actually much smaller. There probably obesity is something different, and I agree that probably in those populations what we see from clinical trial might not be completely applicable, but probably that's definitely not the case in India. And then I just wanted to ask, is it reimbursed, GLP-1 receptor agonists here, so you can prescribe?
Yeah, it is available.
Oh, okay.
Yeah, just few months. We were
Is
having
it reimbursed or patients need to pay?
patient need to pay.
Okay. How much does it cost per person?
It cost around, earlier few dosages cost around 17,000 Indian rupees,
Yeah.
and the higher dosages cost up to 20 to 25,000.
Okay,
Per
and
month.
patients are paid
Per
for
month, yeah.
that. Okay.
So it's not reimbursed by any of the.
Can I ask a question? What is your clinical profile of a patient to whom you will prescribe tirzepatide?
Yeah, is basically those who have higher risk factors for cardiovascular disease or who are already established cardiovascular diseases, like those who have heart failure with preserved ejection fraction or reduced ejection fraction, obese patient, particularly diabetic population. So weight reduction is where it is required, and where there is a very high risk where I cannot send the patient for bariatric surgery because of multiple risk factors, or patient is having coronary artery disease. So definitely these drugs helps them to go some kind of weight reduction.
And what is your threshold over NT-proBNP or BNP will be for the patient, for obese patient, to define him eligible for GLP-1?
There is no such whatever the standard is there, we don't have weight adjusted NT-proBNP levels. So it is age related is there. So less than 75 and more than 75, atrial fibrillation and non-atrial fibrillation, we don't have weight adjusted NT-proBNP levels mentioned anywhere.